Well, happy, beautiful, amazing day. Welcome to this edition of the Dr. Bob Rakowski podcast. And I've got a man that I know very well, Dr. Cristin Matthews, who, by the way, has made my body better. And that's his commitment to the world, one joint at a time. He was a sports surgeon, orthopedic surgeon, doing a lot of robotics, a lot of hips, a lot of knees. Dr. Chris, happy, beautiful day. Welcome.
Thank you. I appreciate it. It's a pleasure.
Yeah, I always like the backstory. So, how did you get to be an orthopedic surgeon? What did you have an injury? Did some fascination? Where'd it go? How did you get there?
Yeah, so I was actually, as a child, my father is a physician, and so I was really interested in medicine, but I didn't know all the different types of medicine. And so when I was 16 years old, I was playing football, tore my ACL, and of course, the story of the surgeon who has a surgery at some point kind of dictated my career. And I got to spend time with my orthopedic surgeon. Unfortunately, I had a few complications through that procedure, but that just meant I had more time with him, more time in rehab, and I really fell in love with musculoskeletal medicine. And that's when I kind of knew I wanted to be an orthopedic surgeon. Little did I know, though, how difficult of a process it is to become an orthopedic surgeon. Once you get into med school, it's a task. But within med school, you typically have to have really, really high marks. And thankfully, I had a great group of people I studied with and awesome teachers that motivated me and kind of geared me in preparations for my exams. And thankfully, I was able to become an orthopedic surgeon. But once I knew I wanted to do musculoskeletal medicine, my idea of where I wanted to go, whether I wanted to go into foot and ankle surgery, spine surgery, sports surgery, joint replacements, pediatrics, I I as a jock at heart, I really love being out there and seeing people get back to their peak. And so sports medicine really called me. And I did my fellowship at Methodist. From there, got the opportunity to work with high-end athletes, being part of the World Series Astros, and then working with high school teams. It really drove my passion for sports medicine and minimally invasive approaches.
Well, I love how you said that people can bounce back to where they were before, because it wasn't that many decades ago that you could give it up, right? If you blew an ACL, you were done. We got people like Adrian Peterson. I believe he blew his ACL before the end of a season and came back and ran 2000 the next year. So how is that even possible? What has changed in surgery that makes that recovery that much faster, that much more thorough?
I think we have become a lot more aware of anatomy is there for a reason. We are designed for a certain reason, and everything matters. And before, we used to just recreate some anatomy, not paying attention to the small nuances. And as we've grown, we've learned these small nuances. We're able to replicate it, which has allowed patients to get back sooner because now the anatomy creates function. The function provides you purpose. And so now that we're able to recreate the anatomy more normally, patients are able to get back sooner. Also, back in the day, we were opening up these joints and huge incisions for such a small tissue structure. Now we're doing it through little tiny poke holes, and we're doing a lot of crazy work through some small incisions. So surgery is advanced that way to become more minimally invasive, to recreate more normal anatomy, which recreates more normal mechanics and gets people back to normal action faster.
Well, that's one thing that I'm amazed at. So, I don't mind giving a little of my personal history. You did my total hip replacement, and I want to talk about that process a little bit. But I mean, I think the incision is 2.5 inches long. You didn't cut a single muscle, and I was walking without pain within a few hours of that surgery. I mean, how's that possible? I couldn't take a single step without 9 of 10 pain, and within hours, boom, there I am, pain free. How's that even possible?
Well, your story is not everybody's story because you are tough, and you are active and you're motivated. So you are the perfect patient to have this done through the front without cutting the muscles. Also, being thin helps out as well. But through anatomy, we're able to find muscle sparing planes and we're able to get in between those muscles instead of cutting the muscles. And using robotics, we're actually able to help personalize it. So we're not taking any extra bone out. With robotics and advanced imaging, we're actually able to create a three-dimensional model outside the body, figure out what size implants and how we need to put the implants in to match that anatomy. And then the robot helps us execute the plan that we've been able to create. And so that approach and those styles have continued to grow. The direct anterior approach was something that was really not discussed or done much in 20 years ago. And the past couple of years, it was the first time at the American Hip and Knee Society meeting where most of the surgeons actually said that they do their hip replacements through this approach now. So more and more surgeons are being trained by it. More and more surgeons are getting comfortable with robotics and understanding how it can play and make a big patient difference. Because before we were just trying to get patients to match the implant, and now we're actually making the implant match the patient.
Wow. I mean, that in and of itself is a huge advancement. I have a patient that was in this week. By the way, I tried to send him to you. He had a failed hip surgery. I don't think it was
Yeah.
done by a robot, and he had a revision.
Mhm.
Why in the world, if the data is there, and I believe it is, that you can be so much more precise, why is not every single orthopedic surgeon using robots at this point? It seems, at least in this country, right? I mean, if we're in a third world country, they can't afford one, different story. But
Mhm.
why wouldn't everybody do it?
I think the trend is going more towards robotics with various different companies. However, as we're getting more and more of this data, we are learning if the precision really makes a difference. Sure, the x-rays look great, but does it make a big difference in patients' lives? And that's where a lot of the data is still missing. We see that patients tend to have less inflammation, less mechanical issues. It tends to match their anatomy a bit better. But some of that data, because it takes sometimes decades to collect, is still up in the air. We're still getting that.
Yeah, I want to go to the knee for a moment because you had a knee surgery, you had an ACL. The knee, if listeners don't know this, it's considered the most complex joint in the body. And for that reason, you got to get everything pretty doggone perfect to make it work. So, how much latitude is there for error in something like a knee? I'm imagining in a younger person a little more, but how can we minimize the challenge in recovery and optimize the matching of the anatomy and the function?
Yeah, the knee and the elbow are some of the most difficult joints in the body. The one thing with the knee is that the knee bears a lot of weight. So when you're walking, there's a lot of brunt, and there's a lot more degeneration that can occur in the knee. The elbow, thankfully, has a lot ranges of motion. You bend it, you can rotate in your elbow too. But with the knee, because it takes so much weight when we're walking upstairs, when we're even sitting down, when we're driving a car, there are so many different ways that the knee can deteriorate. And the anatomy is so critical. I think even when we're looking at ACL surgeries before, along with ACL injuries, the meniscus, which is a shock absorber that sits in between the bone, was something that was thought as a vestigial structure, like the appendix, like something we really didn't need. And so 20, 30 years ago, if we saw that it was torn, we were cutting it out, thinking, all right, we got the ACL, we got the brake back on the car, but the car can still ride just fine without the shock absorber. And now we know that even 20 years down the line, it doesn't matter if you do an ACL right. People degenerate. That knee will fall apart quickly and form arthritis. And granted, yeah, they have their ACL, but now they have no cartilage. And cartilage is what's gold in joints.
Now, interestingly enough, I've seen a lot of patients, certainly a lot of knee surgeries. I've seen a lot of knee replacements. It seems to me the people that have the replacements do better than those that have a repair. Have you seen that, or what's your experience there?
So I think it's also come down to expectations. Oftentimes, patients that have the reconstructions, where they have their ligaments rebuilt, those tend to be high end athletes that have really high expectations, and it takes a long time. It's a biology of healing. And oftentimes, athletes do not have the patience for that. Meanwhile, you have grandma who is getting her whole knee rebuilt, and she's just happy to walk down the street. So the expectation is different. Um, Certainly, with those kind of rebuilds, when we're rebuilding a whole knee, you heal with steel. So the biology really isn't there. You can't expect an 80-year-old biology to heal something versus a 20-year-old. But, yeah, the recovery tends to be a bit faster for joint replacements because you heal with steel and you're able to get walking sooner versus when you're trying to heal soft tissue structures, you have to be more patient. Let that biology take place, and we're still learning ways to expedite it, whether it's through augments in bone marrow aspiration, stem cells, and even advances in physical therapy that can try to help wake up muscles, or even electroshock therapy. There's so many variations in therapy that we're learning to try to accelerate the tissue growth.
So, when it comes to stem cells, have you, are you injecting joints with stem cells, and what are you seeing? What's the indication, and how does that usually turn out?
So we're not really using stem cells like how they used to be advertised before. We do tend to use cells that release a lot of anti-inflammatory markers and healing factors. So some of the things that we do in the office, we like to use PRP, where we take patients' blood, we spin it, we get the growth factors out of that, and that's really used for patients that are typically younger that have good blood, healthy blood, and we inject that, and that can help promote healing. Some of my older patients, I'll tend to recommend, if PRP isn't an option, stem cells, or we call it amniotic tissue. That amniotic tissue doesn't necessarily have cells, but it has a lot of growth factors in it. And those growth factors will kind of promote the body's own growth factors to the area to try to stimulate healing.
And I believe what I heard you say in that reading between the lines is younger people are gonna do better than older people with that. Is that accurate or no?
It really depends. So with PRP and some tendinopathies or wearing away the tendons that haven't fully torn apart, the younger patients tend to have more robust blood. So we're able to spin and get the growth factors out of that blood a little bit better. Versus sometimes when you have an 80-year-old patient, that blood is just not as robust. And to try to get the growth factors out of that may not be as fruitful. So the placental tissue is what I typically recommend in those situations. Another interesting thing that we do is lipogems, or lipogems is actually where we harvest the fat from the flank or the belly. And unfortunately, as we get older, our fat tissue still manages to be pretty persistent. We can still get pretty chubby. And we've discovered that there's cells within the fat that can actually provide reparative factors to the area. And we were one of the sites 2 years ago that started participating in a Medicare funded research study where we were looking at patients that compared um, that when we compared steroids and saline versus fat to see if that helped improve some of their pain. And what we found even before that study was that there are good reports that this can actually help hold off patients that have mild to moderate arthritis for 5 to 10 years.
Now, in the past, when I was looking at that, there was a company called Celltex, and it
Mhm.
was Cell TEX, and they actually described those as being mesenchymal stem cells that they were culturing. Is that the same thought, or is there a
Yes.
evolved thought on that? Okay.
No, that's the same sort of
So
process.
they are
In fact,
actually stem cells the patient's own.
yep, and you're able to pull that through a small incision less than the width of a pen. It's a procedure that typically takes 30 to 40 minutes, and people walk out. And I think it's a great procedure for patients that have mild to moderate arthritis. Unfortunately, when we get to severe arthritis, now we're actually having bony changes too, and nothing is gonna put more rubber back on the tire, right? Once that rubber is gone, unfortunately, now the tire can feel wobbly and, needs to get replaced. But for those people that have little potholes or some mild and moderate wear, it's a really good option.
So I wanna be clear about with 30, 40 minutes, you're literally doing the extraction and injecting, and they leave and they're done?
Mhm.
And then when do they start seeing results if they're gonna see results?
Typically in the first 6 weeks. I've had some patients that right after the procedure was done, they said they never had any pain after that, which I thought was phenomenal.
Yeah, now is it just a fat? Are you mixing saline or what are you putting in? I wonder if it's just a matter of creating joint space and a little gap and a little break and break the pattern, you know?
So that's what I thought too. The fat actually is very anti-inflammatory, and so when we pull it out, we wash it. And with lipogems, they actually have a canister with some metal balls in it. They have filters that are proprietary, and the metal balls break up the fat into tiny little pellets, and then the filter pushes all the cells that are uh, viable or good. It takes away the fibrous fat. And that's the stuff we inject. But really, when we inject it, there's not much fluid left in that fat, and so it does feel kind of squishy initially when it goes in, which can be a little uncomfortable. But patients typically do fine.
Love it. I'm going to do a quick commercial break here. This podcast is brought to you by bettercoffeeshop.com, the world's cleanest organic coffee infused with reishi mushroom, which, by the way, is proven to enhance stem cells. Bettercoffeeshop.com. So I know your specialty is lower extremity. I now have a patient that has had an ankle replacement. I don't know why that's more complex than knee, because the knee is a more complex joint. And I had someone come in who's getting ready for an elbow replacement.
Mhm.
So, it seems that these replacements are expanding. Have you seen anybody? Because you guys do everything. Have you seen elbow replacements, and how's that compared to knee?
The elbow replacement is a very, very difficult procedure, and the indications for an elbow replacement are very tight. Typically, the expectation after an elbow replacement is that you're not able to even lift out more than a gallon of milk, It's very limited. So those elbow replacements, the lifespan of them, the expectation of them is very, very different than a knee replacement.
And what about an ankle?
The ankle is similar too. The ankle we haven't quite mastered yet. For a lot of our patients, we know that people that have ankle replacements, they can burn them out quickly too. And so we'll probably see in the next 10 to 15 years some of those patients that we've done ankle replacements and how well they're surviving, but it's relatively new technology. Before, in the settings of arthritis, they were just fusing everybody, and then you got the stiff joint, which now creates problems along the biomechanic chain of
I could
foot.
not see that being a good idea.
Oh,
I mean, holy cow.
yeah, and with arthritis, when that cartilage wears away, now you have the exposed nerve. It's similar to when you have your tooth chipped and now you've got the nerve exposed there. We've got to find a way to cover it. And so if you can't cover it, you kind of fuse it was the idea. And that's what we were doing before with a lot of joints. And it's still an option for patients that are not good candidates for joint replacements to fuse their joint in a functional position. But it's not ideal.
Well, now, I recall when my hip, I don't know what term to use. I mean, it seemed like I went from very, very, very functional, like, having a martial arts test and doing really well at it, to within a matter of weeks, all of a sudden, every single step hurt. So, what in the world is going on with that fast progression of pain
Mhm.
and deterioration and I'll even say degradation of function? Why does it happen so fast?
It's a great question. There's some patients that have relatively normal looking x-rays where they don't look like they're bone to bone, but they are miserable. And I personally think that it's a stress reaction that occurs within the bone. When the cartilage is lost, there is a lot of force that goes into the bone. And sometimes a pothole can occur. And once a pothole occurs or a sinkhole starts occurring below the surface, that swelling and weakness propagates up and down the bone, which is probably why sometimes you may have even felt like it was going to your low back or radiating down your thigh. And
Yeah.
that's when it's really deceiving, and it's hard for a patient, it's hard for a surgeon to sit there and look at an X-ray and say, "I don't necessarily know why you hurt. Everything looks like there's good spacing. It looks like everything's good, but when the road looks good from afar, you got to drive up close to see the debris." And so that's when MRIs can really help and see that areas where the bone is getting weak and behaving like a fracture.
So have you ever been really shocked? I mean, you open a patient up and you go, wait a minute, this looks really, really good. Or I've seen certainly the other end of that. Oh my God, how could this be this bad and us have missed it for so long? So how often do you see with modern imaging? Probably not that often, but a case where you get in there and it's not at all what you inspected.
Um, Thankfully, my OCD nature won't let me go into surgery without having a good understanding of what's going on. The last thing I want are surprises in the operating room. And so it rarely happens where I'm shocked about how poor somebody's bone is. Thankfully, we have different types of ways of augmenting, whether it's implants that are gripped with cement or implants that we can kind of build on top of each other to make accommodations in the OR for areas where the bone is lost. But there's times where sometimes the soft tissue can be deceiving, and I'll go into a knee replacement and I'll think I'm going to be able to do a simple knee replacement. And then upon an actual assessment after the bone cuts are made, I realize, wow, this ligament that was supposed to be normal really was just barely hanging on. And so we're able to modify those implants for those kind of situations, thankfully. But thankfully, it is not a common situation where I'm caught off guard.
Well, so now you haven't talked to the patient about this. I guess you have a choice. Are you going to do cadaver? Are you going to, rearrange their anatomy? How do you make that decision when the patient's unconscious?
So a lot of this discussion is actually done beforehand. I tell them there's always different options, especially with ACL reconstructions. Typically, for my patients that are below the age of 35, I recommend they use their own tissue. That's what they use the NFL. And the reasoning is tends to be a lower infection rate, a less rejection rate because you're using your own tissue. Now, the problem is when you use your own tissue, you're robbing Peter to pay Paul. And now you're going to get muscular pain from the harvest site. And so sometimes it's worth it in those situations. However, now those patients between the age of 30 and 40, I tell them it's a toss up. I say, you can potentially have the cadaver. Oftentimes, you think about your car, and if you lost a part and you need to go to the junkyard, you can't get a new part. Your car is one of a kind. You can't get that part all over again. So you might have to go to the junkyard, but that junkyard part might be younger than your actual parts are. And then so in those situations for my 40-year-olds, they're like, "Yeah, I'll take the 20 or 30-year-old cadaver tissue. I'm happy with that." They have less pain, but there can be a slightly infection rate or a potential rejection rate.
So I like that you're very, very diligent before that patient ever gets on the table. Now, if you are gonna take something from them, and let's say the anatomy looks a little different, I mean, what's the typical? Is it the long head of the or is it the bicep femoris? What do you use when you're patching a knee? And
Mhm.
what if that's not an option? Now what?
So, for ACLs, typically, I like to use a quadriceps tendon.
Quadricep
Um
tendon?
Yeah,
What did you do? Just
it
take a little piece of it?
yeah,
Certain percent or
the middle centimeter of it,
okay.
and I take a little tiny bone block off the patella too, and I take about 80 millimeters of that strip right down the middle, and I'm able to close that back and put a little collagen patch to help it heal.
So when you say you're
That
taking the middle, you're cutting out the middle and then reconnecting both sides of it?
Yep. Mhm.
I wonder who came up with that. That actually seems pretty brilliant.
Yeah, so back in the day, actually, we were doing a lot more patellar tendons, and I was even a patellar tendon patient. The problem with the patellar tendon is when you take a knee and you're looking up to your coach, your knee hurts. That area is not very forgiving. It is a very sensitive spot. And so patients started looking more towards other areas where they could harvest. The hamstring was a great harvest. When we looked at hamstring grafts, we found that hamstring grafts were actually some of the strongest grafts. However, it did not help the actual mechanics of the knee. And now the hamstrings are a secondary stabilizer to prevent your knee from sliding forward. Now you've taken the ACL's gone, so it's lost its primary stabilizer. Now it's lost its secondary stabilizer. So even though you have a great graft, you haven't improved the mechanics of the patient, and then tends to be a higher failure rate.
My thinking being a biomechanical guy is that in too many people, the quads are already dominant. And if you take something already weaker and weaken a little further, you make the imbalance a little bit worse.
Exactly. So
You know,
the quad has been a great way of doing that, and it hides well for women because they can still wear their skirt without seeing a scar there.
I have a very unique case of a woman who had her patella removed
Hmm.
50 years ago. You know, imagine, well, you don't have to imagine, you probably see, I don't know how often you see someone without a patella, but that joint is destroyed. You know, I'm doing acupuncture and I get her some relief, but I asked her, you know, listen, you really need to have a conversation with orthopedists and consider a replacement. She says, I'm not a candidate. Is that accurate? If you don't have a patella, can you get a replacement?
You can absolutely get a replacement because it helps the patellofemoral and tibial. I'm sorry, it helps out the femoral and tibial compartments.
Well, next time I see her, I'm going to send her your way. But I thought in this era of 3D printing cadaver replacements,
Mhm.
it doesn't seem that it'd be impossible to replace a patella.
No, it would definitely be doable because when we're talking about arthritis, typically in the knee, we're talking about the space that's between the femur or thigh bone and the shin bone, not necessarily the space between the femur and the kneecap.
Well, let's go now with some of your favorite, well, preventive strategies. You know,
Mhm.
someone comes in and, yeah, you know, okay, if we do this knee, we're going to have to do another. How can we make it last longer? Same thing with hip or whatever. What are your best strategies there?
So I think I like to describe cartilage like a tire. You know, if already got a bad tire, you've worn it out, you've gone off-roading, and now you're kind of like, all right, I got to keep this tire around as long as I can. Low impact activities, swimming, cycling, elliptical machine. I'm not a big proponent of keeping people sidelined. I think it's important to stay active, stay moving, and keeping your weight low. So, a lot of us, we're built like different cars. Some of us are Mack trucks, some of us are smart cars, most of us are kind of in the middle. Meanwhile, some of us like to go off-roading. Some of us just like to go around the corner to go to church or the grocery store. And so there's going to be different types of wear that occurs on our knee. But when we start having some degenerative changes, we have to be smart about how we use our cartilage and when we use our cartilage. And also the type of stuff we carry. So losing weight is huge. For every pound you lose, it's 4 to 10 pounds of pressure off your joints. Also, a low inflammatory diet makes a big difference. We are in an area that is extremely inflammatory. There's more things I see in Houston that I didn't quite see elsewhere in the country. And I think some of our diet and our environment plays a role. But the things we can control are what we eat. So if we look for a low inflammatory diet, we look for antioxidants, things like that, that will help take stress off the joints. Because once you start this process of stress in the joints, the body will want to attack itself, and we have to try to find ways of reverting that.
Let's talk about the difference between men and women, right? So first of all, what's different between a male knee and a female knee? And then we'll go up to the hip joint or pelvis. And how does that change your approach, or does it?
So there are some few companies that actually have different types of replacements. Women's needs tend to be a little bit more narrow. Needs tend to be a little bit more wider, and the bone quality can vary too. Men's bone tend to be harder. Women's bone osteoporosis can set in. Their bone can be a little bit weaker. So there's definitely considerations that we have to take intraoperatively, but then also before surgery, looking to see what their function is. Women tend to have wider hips. Because they have wider hips, their knees tend to be more inside. So women do not tolerate being knock-kneed well. Men tend to be more bow-legged. And so it's just the kind of the way the body deteriorates, and just based on how our body's built, that can dictate a lot of that stuff.
Now, are you seeing more men in terms of, athletic knee injuries or women? Or I guess, how would your demographic, would it differentiate? I guess with sports, maybe you see more, but I don't know. How
You
does it
know,
break down?
ever since women had a lot more opportunity in sports, we are actually starting to see a lot more women with arthritis than we did beforehand. I mean, some of us see people that have had 3 or 4 ACL surgeries, and they're like, "Hey, can you do my ACL again?" And I'm like, "Well, no. At this point, there's no cartilage left in your knee, and sure, I can do your ACL, but you still got no tread on the tire. You gotta just get a knee replacement." So we're seeing a lot more of these patients, and I think for women too, because they tend to be a lot more quad dominant, there's a bunch of factors that predispose them to a lot more injuries than men, especially around the knee. Um, One is that their hips are wider than their knees, which cause them to be a little bit more knock-kneed, which predisposes you to an ACL. Another is there sometimes the way the ACL lives in that notch, that spacing between the two parts of the knee. That notch tends to be more A-shaped instead of U-shaped. And when it's more A-shaped, that can actually cause that ACL to almost get a guillotine with certain motions and cause that to rupture. And women also have it harder go because of their period. During their cycles, their ligaments become more lax, which can change their body mechanics and predispose them as well. So now that women are becoming a lot more active, participating in sports like basketball, soccer, rugby, things like that, a cutting nature, um, there are a lot more of these knee injuries that are occurring. And I think next 20 years down the line, we're going to see a lot more of these athletes coming in, and that balance is going to be a lot more equal.
Yeah, I'm certainly seeing a whole lot more of it, and I'm hoping that as people get the idea that nutrition's important, we can
Mhm.
improve upon that. Now let's go to the hip. So we know the pelvis is different. Is actually the hip itself different as well? And if so, how?
Yeah, the women's hips tend to be a bit wider, and so when they're wider, that means the load that they put on their body, those muscles have to hold on a lot more. So I see a lot more of the rotator cuff muscles of the hip bothering patients. We call it greater trochanteric bursitis, but what that means is the little sac that sits between the muscles on the side gets irritated, and that's that pain that patients feel when they're laying down on it, or they're trying to get up from a seated position. They feel it on the side. That we see a lot more because those muscles, because they have to go around the hip a lot further than on men. Men tend to have more narrow hips. That muscle tends to fire up a lot more and hurt them. And so oftentimes it's really physical therapy, strengthening, and trying to see if we can get the biology to kind of change, get the inflammation down, get them to be active again, to try to change that biology to get them back in action. Because we have not really come up with a great surgery for that yet.
Now it's just kind of fun questions. Youngest patient you've ever done a total joint replacement on, and oldest you've ever done a total joint replacement on?
Great question. So youngest, probably 22.
Okay.
I was shocked when he came into my office. He walked in, not well, but when I looked at his X-rays, I thought this kid would have been on a wheelchair. And he had what we call hip dysplasia. Hip dysplasia, we hear about this in dogs all the time, but there's a certain percentage of the hip, which is a ball and socket joint, where the socket is supposed to cover the ball. What happens though in hip dysplasia is that that socket never really forms. And when it doesn't form, now that ball is sitting and kind of floating around a bit more. And this is like having a tire that's placed and that tire is not evenly placed on the ground. When that tire is off like this, the edge that's against the ground is going to erode a lot faster. It's a lot more pressure in that small amount of area. Similar in hip dysplasia, this poor kid had about 60 years worth of mileage in 20 years. And in that situation, when the cartilage is lost, because cartilage is gold, you have to pretty much replace it. And I did a hip replacement on him. Unfortunately, he felt so great that he got on his motorcycle about 3 weeks later and got into a motorcycle wreck, and I had to patch him up again.
Oh,
But it was that was the youngest patient I've ever had to do a joint replacement on, but that's just because there was just no other option. I really try to look towards other biologic options or behavioral strategies because these joint replacements don't last more than 20 to 25 years. And so you have to take into consideration the second time you go in and you put it in, it's not going to be as good. It's going to be a lot more trauma, and they might still have pain.
well, since it was dysplastic to begin, did you have to really create essentially the right joint and the right socket and the right ball? And
Yeah, absolutely. And that's where robotics was absolutely critical for me because I got to sit there and look at the anatomy instead of looking at it through an incision where I'm kind of looking at something from afar. I got to look at the anatomy three-dimensionally and look to and say, really decipher where that implant needed to sit to be as natural as possible before I even made my incision.
love it. And how about the oldest?
I so unfortunately, hip replacements are a really, really common thing, especially in patients that fracture their hip. And so I've done it on a 95-year-old who was extremely active, and unfortunately, she broke her hip, but then the rest of her cartilage was kind of already worn out too. So we just did a total hip on her, and she bounced back great. She said the pain that she was having the time before she even fell was gone.
I think my first patient that had a total hip, this was well over 30 years ago. She's not with us anymore, but her very first day out on the golf course after a total hip, hit a hole in one.
Really?
And she was in her 80s. So,
Oh, God
yeah.
bless her. That's awesome.
Yeah, that's fun. I can't believe that we've already gone over 30 minutes, which tends to be our magic recording time. What message do you want to leave our listening audience as we wrap up today?
So I think joint health is important, but more importantly, lifestyle is the most important. There's so many things we can change with our bodies and what we do when we put into our body, what we expose to our body, how we rest our body, that can really prevent a lot of these things. As a doctor of osteopathic medicine, I believe in a holistic approach. And so I think, when you are hurting, take an opportunity to reflect on your actions and see what you can do to help yourself out. Find ways of trying to live better. And if you can't do that, now it might be time for surgery.
Very, very, very well said. They're making joints great again, one joint at a time. Dr. Chris Matthew, All-American Orthopedic, Houston, Texas. Look him up if you need a referral. I'll happily send you one. Your whole crew is amazing. I love your expertise, and better than that, I love that you love what you do and you're passionate about it. So thanks for making our wonderful world better.
Thank you for the opportunity. I appreciate you.